Tom, and thank you all for attending today. This is going to be kind of a difficult presentation. I see there's a lot of sound competition here, so hopefully you can hear me in the back of the room. As a disclosure, I am a member of the Scientific Advisory Board for Vapotherm and have used Vapotherm technology for many years in our units. When I'm not doing that, which is where I spend most of my time, I am at Rainbow Babies and Children's Hospital in Cleveland, where I lead the Division of Critical Care Medicine. Today, we're going to talk about bronchiolitis and characterize its various etiologies, understand the epidemiology and pathophysiology of bronchiolitis. We'll characterize signs and symptoms of bronchiolitis and place high-flow therapy and its role in the treatment of these patients. And we'll review some selected literature that is relevant to this topic. As you know, bronchiolitis is an acute inflammation of the bronchioles that is characterized by mucosal swelling and mucus buildup. It's generally caused by a viral infection such as RSV. It is highly prevalent in young infants. In fact, it's the most common cause of hospitalization for infants in the United States. If you look at cohorts of patients, both in the emergency department or in the inpatient unit, RSV is by far the most prevalent etiology. 64% of patients in an emergency department sample, or 48% in the inpatient sample. And if you add the co-infections with rhinovirus or human metapneumovirus and RSV, that amounts to nearly 80%. If we take 1,000 children under 6 months of age infected with RSV, that will generate approximately 100 office visits and 55 emergency department visits and 17 hospitalizations. So this is obviously a significant health problem in the United States, especially for those of us that practice in the acute care setting. From a pathophysiology standpoint, you have increased mucus production, which coupled with mucosal edema will lead to an obstructive pattern. And some patients actually have a constrictive pattern as well, which will lead to atelectasis, air trapping, labored breathing. And the direct viral invasion can actually damage the respiratory epithelium and alveolar cells and cause cell death and cellular debris, which further compounds the obstruction that you see. Infants are significantly affected by RSV bronchiolitis, mostly because of their smaller airways, high closing volumes, and also there is a subset of infants that present with RSV with apnea and not with respiratory distress. After the acute onset, recovery starts at about 3 or 4 days for the bronchiolar epithelium, but the full mucociliary function might take 2 or 3 weeks for full recovery. So this is a process that has long-lasting implications, at least in the acute phase. We'll talk about some of the clinical features of this entity. All of you, I'm sure, have seen a sick child with RSV bronchiolitis. They present with tachypnea, tachycardia. Some are febrile, fever might be as high as 38, 39 degrees centigrade. They present with intracostal, subcostal retractions, nasal flaring, and on auscultation, diffuse wheezing and crackles. The AHRQ has guidelines to help us decide which patients should come in for inpatient observation and who can be sent home. You can do an analysis with respiratory factors, nutritional factors, and social factors. So with respiratory factors, if someone is profoundly tachypnic, so a respiratory rate in excess of 70 or uncomfortably tachypnic at any rate, that patient deserves to be watched. Patients that are apneic for obvious reasons should be kept in the hospital. Those that require oxygen or that have clinical deterioration should come in for closer monitoring. If a patient is unable to maintain oral intake or is dehydrated because of the tachypnea and inability to take fluids, those patients deserve hospitalization. And of course, if you cannot discharge this patient safely home, so if the caretaker is unable to provide care at home or there are inadequate home resources, that's also a good reason to keep this patient in the hospital. There are 2 typical patterns of chest X-ray that we see in the ICU with patients with bronchiolitis. One is this, which is a hyperinflated chest X-ray. You can see diffusely hyperinflated lung fields with some peribronchial thickening. And the hyperinflation is quite obvious on the lateral view with very flat diaphragms and precordial air. The second pattern that we commonly see is this infiltrative atelectatic pattern. So you see here hyperinflation of the right middle and right lower lung with right upper lung atelectasis, left lower lung atelectasis with air bronchograms and infiltrates. So two very different presentations. Treatment is largely supportive. There is no definitive treatment for RSV, and at present only oxygen has been shown to be advantageous in improving outcome in these patients. Medications have a very limited role. That includes antivirals, corticosteroids, albuterol, epinephrine, or hypertonic saline. Mild cases come into the hospital mostly for closed cardiorespiratory monitoring and pulse oximetry. Oxygen, again, is the mainstay of treatment and maintenance of hydration. But the more severe cases might require escalation of care, including positive pressure ventilation, non-invasive ventilation, or mechanical ventilation. Traditionally, respiratory support for the patient with severe bronchiolitis started with low-flow oxygen, leading to non-invasive ventilation through a nasal prong or face mask, and for the sickest patients with respiratory failure, mechanical ventilation. High-flow therapy, which is the device I would like to talk to you about today, is an alternative to that that provides clinically effective and comfortable respiratory support through a simple nasal cannula. It consists of introducing conditioned gas at very high flow into the nasopharynx through a nasal cannula. And what it does is it flushes the anatomical dead space and creates a gas reservoir that is CO2 poor. So you are essentially purging the CO2 from that alveolar, from that anatomical dead space, and it creates also a reservoir for oxygen. There is a slight positive pressure that is generated during high-flow therapy, but that pressure is really not sufficient to be clinically relevant. I would say that under optimal conditions, you have a pressure of about 1 or 2 centimeters of water. So it's really not the main mechanism of why high-flow cannula work. But it does decrease work of breathing, and it allows the patient to breathe through his or her own airway without the need of an external source, such as a mask. When you do gas flow dynamics modeling of what's happening inside someone's respiratory tract under high flow cannula, you can see that there is a turbulence of flow in the nasal cavity and nasopharynx that eventually permeates into the hypopharynx. We can't repeat that apparently, but and it completely purges this anatomical dead space of gas that was there from the previous exhalation and therefore is rich in CO2. So by moving the source of fresh gas from the tip of the nose to the hypopharynx, you significantly decrease anatomical dead space, and that has advantages as far as breathing. When you breathe spontaneously, fresh gas in red gets to the lungs, and then CO2-rich gas is exhaled. And it's going to be inhaled again at the beginning of the next inspiration before you get a source of fresh gas. With high-flow therapy, the source of fresh gas has been moved to the hypopharynx, so it purges the CO2-rich expired gas and again decreases anatomical dead space, which is advantageous because you can then maintain adequate CO2 elimination without having to improve your minute ventilation. You can do that, and that I mean is apply high flow of medical gas into someone's airway, mostly because it must be fully heated and humidified. So the gas has to be perfectly conditioned for you to do that. If you try to blow 20 liters of flow into someone's airway without proper conditioning, very quickly that mucosa will cool, it will become hypersecretory, it might dry. So you need the proper conditioning for that to happen. So the Vapotherm device allows you to do that. Proper humidification and heating improves mucociliary clearance, and it also decreases energy expenditure. For one, you are offsetting the highest resistance of the airway, which happens in the exothoracic airway. And second, you have lower energy expenditure because you don't have to spend energy to heat up the gas or hydrate the gas as we normally do when we breathe standard tidal volumes. So the potential clinical impact is that we will reduce work of breathing because of the dead space flush. We will be able to provide a precise oxygen concentration delivery to this patient. It will allow us to manage secretions much better than with an occlusive CPAP or BiPAP mask. You can imagine a 6-month-old infant with severe RSV and profuse secretions that needs to be suctioned 4, 5, 6 times an hour. And every time you suction this patient, you have to remove the nasal CPAP mask, suction the patient, try to place it back without leakage. That can be very easily accomplished with a simple nasal cannula connected to a high-flow device. Additionally, unlike the positive pressure CPAP or BiPAP devices, high-flow cannula allows one to feed the patient through high-flow therapy. When we think of a high-flow system and what it does to purge the nasopharyngeal cavity, we rely on delivering gas that is fully conditioned with optimal temperature and humidity through an open system at high flow rates. What I mean by an open system is that the occlusion caused by the cannula has to be less than 50% of the nares. So what you see here is a properly sized cannula with a significant leak around it. When people attempt to upsize a cannula to make this look like a nasal prong, that's where you get into trouble, because you can generate significant pressure if you don't have a way of leaking, and that can be an issue. So we strongly recommend that high flow therapy should be done properly, respecting at least 50% leak for the cannula sizing. In fact, there is now a cannula called a solo cannula that delivers high flow through a single prong, and therefore it ensures that, that you'll have at least 50% leak on the other side. The medical grade vapor is fully conditioned through a cylinder. It's a cartridge that has hollow tubes through which gas, the medical grade gas, oxygen and nitrogen will go through. It is then hydrated to full humidification by permeation of vapor, water vapor through this hollow wall. And then the gas comes out fully conditioned on the other side. Now this is at the level of the machine, and you can understand that there's a big space between the cartridge and the patient. And if we were just to connect this patient to a standard cannula, the gas will cool down as it gets to the patient, and there will be rain out because the water vapor would not remain in vapor form under a lower temperature. So it's very important to maintain temperature all the way to the patient, and this is done through this warm jacket insulation. You will have a liquid phase and a gas phase in the center. So at any given time you have gas moving in the center of this jacket, and a water radiator temperature control that maintains that gas to the proper temperature until it gets to the cannula and the patient. There is a wide operational range for these machines. You can have flows from as low as 1 liter to as high as 40 liters. And you can maneuver the FiO2 from 0.21 to 1, and a wide array of temperature control from 33 to 43. In clinical practice, we go by patient size and weight. So, the neonatal size patients, we generally start at about 4 or 5 liters per minute, and escalate as high as 8 liters per minute if necessary. The 1 month to 1 year, we generally start at about 5 to 8 liters and go as high as 14. 1 to 6 years of age, we usually start at 5 to 10 liters per minute and can go as high as 16. The patients between 20 and 40 kilos, we generally start at 10 or 14, going to as high as 20. And in the teenage young adult group, we start at 12 or 16 and go as high as 30. And if you haven't had a chance to try high flow on yourself, 30 liters sounds like a lot of flow, but it's extremely comfortable when that gas is fully conditioned and humidified. You should try it if you haven't. I want to go into a slightly different topic, just to talk about a concept, and that's that of airway obstruction. This is an X-ray. I don't know if you can see the projection of a patient with a strong steeple sign. So this is a patient with croup and extrathoracic airway obstruction. It could have been a patient with post-extubation stridor as well. And this is a patient with retropharyngeal abscess. So these are patients with extrathoracic airway obstruction that have significant resistance to inspiratory flow. And in partnership with Vapotherm, Praxair has now made available Heliox to be used with a precision flow system by Vapotherm that delivers the same highly conditioned gas but helium instead of nitrogen. So helium is the second less dense element on Earth, and when you take such a low density gas as your carrier and you mix that with oxygen, the resulting gas, Heliox, has a much lower density than air, which uses nitrogen as its carrier gas. So by using Heliox, we can decrease resistance in areas of turbulent flow, and by decreasing resistance, we decrease driving pressure needed to move air in and out, which translates into decreased work of breathing. So key applications of the Vapotherm Heliox technology would be for patients with extrathoracic airway obstruction, such as croup or post-extubation stridor. It decreases, again, the pressure across that fixed obstruction. We have used with great success in patients with severe bronchiolitis and severe asthma in the ICU, again, as a way of reducing the work of breathing necessary to move gas from point A to point B on these patients with severe obstruction. An added advantage of that is that we now have pretty good data to show that the particle deposition of nebulized aerosol drug is much better on high flow Heliox than just by inhaling nebulization through a simple face mask. So we use that as an added benefit of the application. I want to spend the last few minutes talking about some relevant clinical studies, and I'll start with one that I'm particularly fond of. This is a study by Dr. Knuth's group in Los Angeles, and it was just recently published in Pediatric Critical Care Medicine. This is a very clever study where the investigators placed an esophageal probe in babies that were being mechanically ventilated and used that as a surrogate marker of intrapleural pressure. So patients were ventilated, and just prior to extubation, they were placed on CPAP mode on the ventilator, and what you see over here, a pressure of 5.8 centimeters of water, is the pressure that was being applied via CPAP to those patients. Patients were then extubated with the probe in place, and they were randomly assigned to various flows of low flow and high flow therapy. And what they saw was that just by the application of a simple nasal cannula, the measured pressure was 4.5 centimeters of water. That's the pressure of the esophageal pressure on those patients. And that the application of high flow therapy did not significantly increase that pressure, so that with 8 liters, you had a pressure that was only 5.4, so it's less than 1 centimeter of water greater than during spontaneous breathing. Something that the investigators were able to do, because they were able to quantify pleural pressure, was to create a composite variable called the pressure rate product. Pressure rate product takes the swing in intrathoracic pressure, which is a marker of respiratory distress, and the respiratory rate, which is, again, a marker of disease severity. And by multiplying the two, they create a composite variable that the lower the number, the more comfortable the patient is. So with 2 liters of nasal cannula versus 5 liters of high flow nasal cannula versus 8 liters, there is a steady decline in the pressure rate product, showing these patients were actually responding and getting better. I want to talk about this. This is a classic study in the high flow literature. This is a study that was done in New England, published in 2010. This is the description of the introduction of high flow cannula pre and post in 2 RSV seasons. So the picture on, or the column on the left is pre-high flow cannula. We're going to call that control. And this is post-high flow cannula. We're going to call that intervention. The groups are pretty much the same, except that the high flow cohort had a higher respiratory rate of 61 compared to 47. The other difference is that, as you would expect, no patients on the pre-high flow control were treated with high flow cannula, and 87.9% were treated with high flow therapy in the second cohort. The comparison between these two samples show a significant reduction in the need for endotracheal intubation, going down from 23% to 9% with the application of high flow cannula. From a physiologic variable standpoint, respiratory rate decreased significantly, 6% on the control group, 18% reduction in respiratory rate on the high flow nasal cannula cohort. And the PICU length of stay was also significantly reduced, probably as a reflection of the lower need for mechanical ventilation in this study. The last study I want to talk to you about is an Australian study published a couple of years ago. It's a retrospective study of 298 patients, the majority of whom had bronchiolitis. And they describe the adoption of high flow therapy in this ICU as it relates to the need for mechanical ventilation. So what you see here is in blue, the percentage of patients treated with high flow therapy in 2005, which amounted to 13%, and the number of patients that require mechanical ventilation, which was 37%. And as this therapy became more accepted and more used in that ICU, there was an increase from 13% to 66% of use of high flow cannula, and a decrease from 37% to 7% on the need for mechanical ventilation in that unit. Now, one might say that's just the effect of time. Perhaps that's just how medicine advanced over those years, and that doesn't reflect the effect of high flow cannula. But the investigators then looked at in a contemporary sample of the Australian New Zealand Pediatric Intensive Care Consortium, and looked at all the other units that were practicing without high flow, and those units had a substantially higher rate of need for intubation and mechanical ventilation with a contemporary sample. So I think it's fairly safe to infer that, that the effect that was seen here was a gain from high flow therapy. Something that I find interesting about this study is that it gives us a guidance as to how quickly these patients respond. So if you look at the heart rate, for instance, and you have two groups here, an open circle group, which are patients that responded to high flow therapy, and a closed triangle group, there are patients that require escalation and additional support. You can see that after initiation of therapy, within 30 minutes, these groups were already separating. And by 60 minutes, there was a pretty clear difference on patients that responded or did not respond. The same is true for respiratory rate. So by 30 minutes after initiation of high flow therapy, you already see a separation between the groups. And by 60 minutes, responders have already declared themselves. And we see that daily in clinical practice. Patients become almost immediately comfortable if they're going to be responsive. Some patients are just too exhausted and they are beyond the point of benefiting from this technology by the time they get to us. And some patients just have progression of disease and require escalation of support. But if we think of RSV or severe RSV bronchiolitis in the ICU as a disease that runs a course of a crescendo, a peak, and a decrescendo, the beginning of that syndrome can be managed by standard oxygen. And up to not too long ago, those patients that failed to maintain proper oxygen saturation or are just too tired or leading to respiratory failure will be placed on CPAP or bilevel non-invasive ventilation, and a sizable percentage of them will progress to respiratory failure and require mechanical ventilation. As they improve, some units extubate patients to non-invasive ventilation. Our practice is to extubate patients to nasal cannula. And high flow therapy fills a very important gap in the continuum of care of those patients, because now, as these patients are getting worse, I can deploy high flow therapy, and in many occasions, completely bypass non-invasive ventilation and significantly decrease the percentage of patients that will require positive pressure breathing. So I've been an early adopter of this technology. We use this daily in our intensive care unit, and you know, we are to the point I don't see how we could practice without it. So